All right, so in this lecture of Unit 6, we're going to talk about biochemistry diseases that affect the pulmonary system. So first, Kartagener syndrome, which is also known as primary ciliary dyskinesia. And the source of Kartagener syndrome is actually defective dynein arms. And if you remember, dynein is one of those motor proteins that moves along a microtubule. So remember, you had the plus end of a microtubule and the minus end. And you had kinesin, which would go towards the positive end of the microtubule. And then you had dynein, which goes towards the minus end, which would be retrograde transport. This would be anterograde transport. And remember, in most cells, that's what the primary function is just moving materials from one end of the cell to the other. And then both of these proteins are ATPases, so they hydrolyze ATP as a source of their energy. Now, in cilia and flagella, dynein actually serves another function where it actually links these microtubule doublets, which together form what's called an axoneme, which is a microtubule structure at the core of cilia and flagella, which both serves a structural function and then also helps with their motile function as well. And dynein in particular, since it links these doublets, provides a crucial role in the motility of cilia and flagella. And so in this structure here, you see 9 doublets, plus 2. Remember, that's the standard arrangement in motile cilia. And so what we really care about is that since this is defective, these dynein arms are defective, you have non-functional cilia. In essence, they cannot move. They're otherwise immotile. And so where that's important is let's say you have the respiratory epithelium here, which has ciliated epithelium like this. So in a normal individual, let's say you have an infection, a bacterial infection, it gets trapped in the mucus, and you have this buildup here. What's nice is that the cilia can just move in unison and essentially sweep out this mucus debris out of the respiratory tract and clear the infection. However, in someone with Kartagener syndrome, this is unable to happen, and so you have continuous buildup of mucus and pathogens within the respiratory tract. Now, the way you can diagnose this is measure nasal nitric oxide levels, and in patients with Kartagener syndrome, they're going to have very low nasal nitric oxide levels. Clinical features: as a result of this process here, they're going to develop what's called bronchiectasis. So this is a cyclical process. You continually have building up of mucus and infectious agents within the respiratory tract. So what that's going to cause is an increase in inflammation. And so the inflammation is going to cause structural damage over time. And so what happens is you have, in essence, distortion of the respiratory tract structure. So you're going to have dilation. And what that's going to further lead to is recurrent or chronic pulmonary infections. And so unfortunately, patients with Kartagener syndrome, clinically, they're going to present with chronic and recurrent pulmonary infections. It also affects fertility in both males and females. So if we come down here and we draw the uterus like this, fallopian tubes that come out like this, and then you have the ovaries here on either end. And so for fertilization, remember, it typically occurs in the ampulla of the fallopian tube. So you have the egg here, and the sperm would come in and fertilize the egg. And then what happens is, so we'll come over here, if you have a fertilized egg, there's actually cilia within the fallopian tubes that will move in unison, just like they do in the respiratory tract, to essentially sweep this fertilized egg into the uterus, where it can then implant onto the uterine wall and develop into an embryo. The problem is if a female has Kartagener syndrome, this cilia, again, just like the respiratory tract, are going to be immotile. And so what's going to happen is, even if the egg does get fertilized, it's going to be stuck within the fallopian tube and implant and result in ectopic pregnancy. So female patients with Kartagener syndrome are at much higher risk for ectopic pregnancies. The other thing is males are infertile because the flagella, like I said earlier, also relies on the dynein arms for motility, and so you're going to have dysfunctional sperm as well. Lastly here, we'll just mention that Kartagener syndrome is associated with situs inversus dextrocardia, which essentially means that the heart is on the right side of the body instead of the left, and also the apex of the heart is pointing towards the right. So this is actually a CT scan from a patient with Kartagener syndrome, and you can see where the heart here is actually the apex of the heart is pointing towards the right versus the left. Remember, in radiology, things are flipped. So this is the right side, this is the left side. And so you see the apex pointing towards the right instead of the left. And really the orientation of the heart is completely towards the right side of the body versus the left, which is the total reverse of normal. So the next disease we're going to talk about is cystic fibrosis, and you need to become very familiar with cystic fibrosis because you're just going to see it come up on a lot of different exams, biochemistry exams, board exams, shelf exams, even beyond that, depending on what specialty you go into. So cystic fibrosis transmembrane regulator, or CFTR gene, is the source of cystic fibrosis, and it's mutated on chromosome 7. Sometimes that can be a test question, which chromosome it's mutated on. Now, there's nearly 1,000 different mutations that will result in cystic fibrosis, but the most common mutation results in the deletion of phenylalanine 508 on the CFTR protein. And this is also a very common test question as well. And so really the CFTR gene is responsible for encoding an ATPase chloride channel that allows for the secretion of chloride into different epithelial lumens in the lungs, the pancreas, into the sweat glands in the skin, intestinal tracts. And so here we have a normal diagram here that shows the normal cellular function. So here's the CFTR protein, and as you can see, it's in the apical membrane of the epithelial cell. And you have chloride here within the cell, and it gets exported out into the extracellular space here, or the lumen of the epithelial tract. Paired with CFTR, you have what's called the ENaC channels, which are sodium transport channels. And so they take sodium from outside the cell and move it into the cell. Now, what's important to remember is that the CFTR protein actually inhibits the ENaC function. And the reason for that is as you expel a chloride out, you want to have a sodium there to balance out the charge. So if you're moving chloride out, you're going to inhibit ENaC and prevent sodium from coming back in. Now, in patients with cystic fibrosis, there's really two types. Now, the majority of patients are going to have a completely absent CFTR. And the reason it's completely absent from the membrane is that the mutation results in misfolding and post-translational error that causes defective transport of the protein, and thus it remains sequestered in the rough endoplasmic reticulum. So you have the rough ER down here, and so you have, the protein in here, and it just can't fold properly in here. And so it just kind of is disfigured and gets stuck in the rough ER and can't make its way up to the cell surface. And the end result is that then you don't have it present in this apical cell membrane to export chloride out. Some mutations will result in the protein reaching the membrane, but that protein is defective and does not work as efficiently. This is, a milder form of cystic fibrosis. This is much more rare. The most common, though, is where it's completely absent from the cell membrane. So we'll focus in on this part of the diagram here to really illustrate the physiology here. So the end result is that you're not moving chloride out of the cell and into this lumen of the epithelial tract here. So this doesn't occur, so you have a buildup of chloride. The other thing is that ENaC then doesn't receive that inhibition, and so what happens is you have sodium continuously flowing into the cell from the extracellular space. So you have a buildup of sodium, which again to balance off the negative charge of the chloride. And then if you recall, where sodium goes, water will follow via osmosis across the cell membrane. So these cells are going to swell. What's more important, though, is you're going to decrease the available water out in the lumen of the epithelial tract. And so what that's going to result in is you have mucus out here, which is just a normal secretion within the epithelial lumen, which is normally thin and watery. And so by removing water, you're going to make this mucus much thicker. So thicker mucus, and this is the source of most of our problems in cystic fibrosis. And so what happens is that this mucus builds up, and it's much harder to clear because it's thicker, it's stickier, it adheres to the surface within the lumen. And so what happens is say, let's have the lungs here. So in the lungs here, you have your respiratory tract like this, and you have this buildup of mucus in here. And so what happens is you can have a buildup of infectious agents here, so bacteria, viruses, and so these patients can develop chronic and recurrent infections. And then having chronic infections and having this buildup of mucus causes significant inflammation, which damages the respiratory tract. You can develop bronchiectasis, where you have deformation of the respiratory tract structure. And again, that just furthers the process of developing infections. Also, the other thing is this affects the digestive tract. So let's draw a little bit of an anatomy diagram here, if you recall. So here's your liver here. And if you remember, the liver secretes bile. So you have the bile duct that comes down like this, and it actually joins with the pancreatic duct here. So this is the bile duct. And then here we'll draw in. Here's your pancreas right here. And then if you remember, these join together, and then they release their contents into the duodenum, which, if you recall from your anatomy days, is the first section of the small intestines. So where this is important is, so let's say in the pancreatic duct, which is responsible for carrying the digestive enzymes secreted from the exocrine pancreas to the duodenum, where they can actually digest food that was just ingested. Again, you have mucus in here as well, and so mucus gets thick and sticky, and you can't clear it out, and so it blocks this pancreatic duct. And then you have all these pancreatic enzymes, these digestive enzymes, that get built up within the duct proximal to this blockage, and then that can really wreak havoc on the pancreas. That can cause significant damage because, again, these are enzymes that are responsible for breaking materials down, and so it can cause significant damage to the pancreas. It can even affect the endocrine function of the pancreas, so patients can even develop diabetes-like symptoms in some cases. This also results in buildup of mucus in the bile duct as well. And so, again, block the bile duct, whether it's a gallstone or in cystic fibrosis, can also have buildup of bacteria and develop infections proximal to that. The other thing is it just builds up and causes increased pressure and damage to the liver. So you can cause chronic damage to the liver. It can even develop into cirrhosis in some cases in patients as well. So as you can see, really causes significant damage in anywhere really there's a epithelial tract. So the respiratory tract, bile duct, pancreatic duct. And then as a result of not being able to efficiently secrete bile and pancreatic enzymes, it also affects the digestive function of the intestinal tract. So patients develop malabsorption as well. The inheritance for cystic fibrosis is autosomal recessive. It's most commonly seen in Caucasians, particularly people that have Northern European descent. Lab tests to diagnose this. So the famous one is sweat chloride levels. The definition is greater than 60 milliequivalents per liter. So let's do a little bit of a review here. So let's say you have some epithelial cells that line the sweat gland duct. And so this will be just the top of the duct here. And so you have these epithelial cells like this. And so again, you're going to have your ENaC channel like this. So here's ENaC. And again, that's going to move sodium out of the lumen. And so that's going to take sodium out. Now the difference is between some of those other, in the respiratory tract and then the pancreatic duct and the bile duct, is the CFTR protein is actually going to move chloride from outside the lumen back into the cell. So you got to remember that it's reversed here. It's a different function in the sweat gland. And the reason for that is to really decrease the amount of sodium chloride that's released in sweat during exercise, because you want to prevent the loss of electrolytes during exercise. Because when you exercise, your body heats up, and then the natural cooling system is to secrete sweat. And so again, it's just a protective mechanism to maintain electrolyte levels, which is very important. However, if this is missing, what then happens is you have sodium gets continually reabsorbed by ENaC, but then you have a buildup of chloride in the sweat that then gets released out onto the skin. And so what happens is then clinically you would collect some sweat samples and then measure the chloride levels, and you would see that it's dramatically increased because it's not getting reabsorbed in the lumen here. The other test here that we have mentioned here is you do a newborn trypsinogen screening. And so what this does is it measures the levels of trypsinogen, which is the precursor to trypsin, which is a digestive enzyme secreted by the exocrine pancreas. And you actually will see increased levels of trypsinogen in the blood because it's not getting efficiently excreted from the pancreas. So it gets built up, it drains out, and it's built up in the blood. And so you see increased levels of trypsinogen in the newborn. And so that can be used for diagnosing cystic fibrosis as well. What typically would happen is you would do this first, and if this is positive, then you do a sweat chloride test to confirm. So clinically, patients with cystic fibrosis are going to demonstrate failure to thrive and premature death, unfortunately. They're also going to have contraction alkalosis due to preservation of water and hypokalemia. And the reasoning behind that is, remember, they have loss of sodium chloride in sweat. And remember, where sodium goes, water follows. And so this is going to really be fluid loss. And so decreased fluid is going to result in decreased circulating volume. And decreased circulating volume is then going to trigger the renin, angiotensin, aldosterone axis. And so really, if you remember aldosterone, so aldosterone does kind of three main things to help restore circulating volume. So one, it's going to stimulate sodium reabsorption. And then two, as a byproduct of that, it's going to stimulate potassium secretion, which is how you get hypokalemia. And then three, it's going to stimulate hydrogen secretion as well. So when you're secreting hydrogen, what that's going to lead to is an increase in the pH, and that's how you get your alkalosis. The other thing you're going to see here on the respiratory side of things is recurrent pulmonary infections. We've mentioned that before, obviously due to the thick mucus. Common test questions will ask what bacterial organism is found to cause these infections at different stages in life. So it's going to be Staph aureus in childhood, and then Pseudomonas during adolescence and adulthood. And as a result of chronic infections and chronic buildup of mucus, patients will develop bronchiectasis as well, which will further perpetuate this cyclical process of damage and recurrent infections. On the digestive side of things, you're going to see decreased absorption of fat-soluble vitamins. And again, that's a result of blockage of bile secretion and then digestive enzymes as well. And if you recall from Unit 4, we talked about the fat-soluble vitamins, which again are D, A, K, and E. And by having decreased absorption of fats, or malabsorption, you're going to have steatorrhea, pancreatic insufficiency, which is going to be due to blocked pancreatic ducts. And then another thing that patients will have when they're first born is what's called meconium ileus. So meconium is the very first stool that's excreted in newborns after birth. And so what happens is that kind of tips clinicians off that patient may have cystic fibrosis is that the newborn doesn't excrete this meconium in a normal period of time. And so because, again, you have buildup of mucus and blockage within the digestive tract itself, and that prevents excretion of the meconium. And so, again, you'll see meconium ileus in newborns. As far as reproductive tract, you will see a congenital absence of the vas deferens in males, which will lead to infertility in males. You also see decreased fertility in women because, again, this is going to affect epithelial lumens all over, and so you're going to see thick cervical mucus as well, which would interfere with migration of sperm through the reproductive tract. Lastly here, you're going to see polyps in the nose and fingernail clubbing. And so lastly here, the treatment for cystic fibrosis, especially since cystic fibrosis particularly impacts the respiratory system, you're going to have breathing treatments, chest therapies, and then albuterol to help open up the airways, help them breathe better. The other thing is you want to replace those pancreatic enzymes that are having trouble getting out of the pancreatic duct. You also want to replace those vitamins, especially those fat-soluble vitamins. Remember D, A, K, and E. The other thing is you can give saline to thin the mucus secretions, obviously antibiotics to treat the recurrent infections. And then here you have a drug combination called lumacaftor, ivacaftor. And so these are two separate drugs given together. And so lumacaftor is a chaperone protein, or acts as a chaperone protein. And really what it does is it acts to enhance CFTR folding, which the hope there is that then that increases the number of CFTR proteins that reach the surface of the cell. And then ivacaftor, what that does is it potentiates, it's actually present at, or acts at the surface of the cell, potentiates the CFTR. And so what that means is that it actually increases the chance of the CFTR protein being open and actually transporting chloride out of the cell and into the epithelial lumen. And together, these drugs act synergistically, so that's why they're given together to help improve the situation. All right, so that closes out our discussion of biochemical disorders that affect the pulmonary system.